Hi everyone, I'm Tony Rivera. I'm the Digital Marketing Coordinator for the Christopher Dana Reeve Foundation. I'd like to welcome you to this month's online chat with Nurse Linda. Nurse Linda has been a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher Dana Reeve Foundation for close to 20. As a moderator in our Ask a Nurse discussion, she focuses on contributing functional advice, providing how-to on integrating various healthcare improvements in daily life and answering your questions. Nurse Linda, take it away.
Well, thank you, Tony, and hello, everyone. It's so nice to have you on the blog again this month. Spring is upon us, and so we're going to be entering into some nice weather month. Unfortunately, where I am, we're having pouring down rain today. So just a caution to everyone to be careful if you're in some wet weather, if you're out and about. There's certainly some thunderstorms going on here. And be careful as we enter into the summertime because there's going to be a lot of days with warm weather, and then we have cold weather, and then rainy weather, and so it's always kind of a challenge to all of our immune systems to deal with all these changes in weather and pressure and all the pollen and everything that's coming out. Looks beautiful, but sometimes it can get a little hard to breathe with all that pollen out there. So this month the blog has been about dealing with pain. We've noticed through the Christopher and Dana Reeve Paralysis Foundation that there's been a lot of people writing in and asking questions about pain. So we thought it would be a good time to have that review about what's going on. And so basically, just to summarize, talking about pain, is there's really two different kinds of pain. There's the pain that we're all familiar with. It's called nociceptive pain. That's a big word, meaning if you get something that hurts you, you get a pain. So if you bump your hand on the table, you knock your hand and it hurts, you have pain for a minute, but then that pain will quickly resolve. So nociceptive pain is whenever you have some kind of incident, event, something that happens that causes pain. If you take away the source of that pain, the pain will resolve on its own. Sometimes you have to have some pain medication, sometimes not. Certainly if you have surgery, that's the something that has happened and you'll have some pain after that, but it will resolve over time. The kind of pain that we're most interested in is the other type of pain, and that's that neuropathic pain. And that's pain that arises from the nerves itself. So some message is being sent through those nerves in your body, and it's triggering the pain. Now, for people who have difficulty with sensation or processing those messages to the brain, so if you've had a spinal cord injury or some other type of neurological impairment through disease, or perhaps you've even had a stroke or you have multiple sclerosis or some other type of neurological problem, this neuropathic pain really can be a bit of a challenge to treat, because it's not like you can take away that stimulus that caused the pain, because it's sort of like the nerves are acting on their own accord. So sometimes we have messages that are being sent from our body, even though below the level of the injury, you might not have any feeling, you might not have any sensation, but your body is still going to respond if it has something that happens to it. So if you're wheeling along in your chair and you bump your foot up against a door frame, happens so very often, your body's still going to notice that you stubbed your toe up against that door frame. And you're still going to have a reaction to that pain. Your body might not feel it exactly the way that it felt before your spinal cord injury. That pain message is going to be sent from the foot up to the brain, but it's going to stop at the level of the spinal cord injury. So sometimes those pain messages get kind of mixed up and disturbed in there. Sometimes there are other triggers that happen in the body that the nerves get aggravated for some reason, and they start sending this neuropathic pain. So there's rather a process to treating pain. Most of the time people will start, they have some pain, they don't really differentiate if it's nociceptive or if it's neuropathic. They just know they have some pain, And so generally what people will do is take an over-the-counter pain medicine because that's what we all do when we have pain. So that seems like a logical thing to do. And every once in a while, those medications will relieve any kind of pain that you have, and you just move on and go on with your life. And, no harm, no foul. You just keep moving along with it. But sometimes that neuropathic pain sticks with you, and it's very difficult to try to get that to stop sending those nerve signals back and forth to the brain. So people will go to the healthcare professional, and they'll start looking for other methods to resolve their pain. Now, most typically in our Western medicine, what will happen is you'll get some different pain medication. So generally speaking, if you can find out the source of what that pain is that's causing that neuropathic pain, generally if you treat the source, then that will help the neuropathic pain. So for instance, if you have increased tone in your body, in that you have tone is what we now call spasms. People are more used to calling muscle contractions spasms. But the technical word that we use for that now is tone. So if you have more tone or spasms, and that's stimulating the neuropathic pain, if you get that tone and spasms under control, then the neuropathic pain will resolve. Sometimes people get neuropathic pain from other kind of diseases or body dysfunction. So maybe you don't normally have neuropathic pain, but all of a sudden you start developing it, and you find that you have a bladder infection. So treating the bladder infection takes away the spasms in the bladder, and the neuropathic pain resolves. That's always very nice when you can figure out what the trigger is and then resolve the trigger. That makes it a lovely process because then the pain is gone. Still, sometimes people have pain and you can't quite figure out what the source is. It's just kind of this chronic pain that's just ever present. And if you've ever had pain, and we all have had it, it's so annoying to have pain. It's so uncomfortable for such a period of time until that pain finally resolves. So having this neuropathic pain that just goes on for hours and days, months, and sometimes years is just very wearing. It's just a bad way to try to create a quality of life for yourself. So some of the treatments that will be tried is to use some medications that will help just decrease the neuropathic pain. Sometimes antidepressants are used for this. Now these are, people hear antidepressant. I'm not depressed. I don't need that. But these are antidepressant medications that are used in much smaller doses, so not even an amount that would affect any kind of mental status or depression or anything like that. So like for depression, you might take the one pill that's 150 milligrams, but for neuropathic pain, you're going to take a pill that's 5 or 10 milligrams of the same medication. So quite a difference in dosage. The key point here is that in using these antidepressants, what happens is as antidepressant, a side effect of the antidepressant is treatment of neuropathic pain and settling the nerves from within the nerves themselves. And so that's why these antidepressants in low doses are so helpful with this type of treatment. Sometimes that will work for people, and then sometimes people that doesn't work so well. So there's another level of medication that you can take, and these are the anticonvulsants. And so you think, well, I don't have seizures. I don't need that medication. But again, here the dosage is different. And so the anticonvulsants settle nerves when they're overreacting, and so the same thing happens in the neuropathic pain. The nerves that are causing this pain are settled so they're not overreacting so much. There are some specific medications that are on the market that will work this way for the nerves in particular. They've been formulated for neuropathic pain. Those medications you've probably heard of, Neurontin and Lyrica. If you've ever had neuropathic pain, you might have been on one of these two medications. There are other anti-seizure medications that are also used, and they're very helpful as well. So it just kind of depends on what works for you. Treating neuropathic pain is very much a trial and error because it's so hard to really distinguish one person's pain from another. So I might say I have a pain, and I might say it's a very extreme pain. We wouldn't be able to tell if you are experiencing the exact same pain that I am, and that you would even relate it to the other, because our life experiences make a difference in what we think about pain. So people who've had a lot of pain in their life might rate their pain lower than people who've not had a lot of pain experiences. They might rate their pain higher. Some people are just more stoic. They don't want to complain. They'll, lower their pain rating. Some people think, oh, I've had this pain. It's been going on for quite some time. I'm going to rate my pain really high so that my practitioner knows that this is really an extreme pain. So there's all kinds of factors that play into this. So that's basically the process. Now, there are many other treatments for neuropathic pain that are used in other cultures and other countries. Some people are very open to these kind of treatments, and some people say, nope, not for me, not even going to try it. So really, if you are open to these ideas of non-medication types of treatments, then that's an opportunity for you to try some of these. If you go in with the attitude that these alternative or complementary treatments are not going to work, then they are not going to work. If you set it in your mind, this is not going to work, it won't. Same thing like if you take one of these pill medications. If you go in with your mindset, no, I'm sure it probably won't work, then it probably won't work for you. Pain is very subjective. So how you feel about your pain and what you think about the treatment is going to rely on how you see and view the world. So some of these complementary treatments might be things like biofeedback, acupuncture, acupressure, even movement of the body. So if you do range of motion, it sounds like, I'm getting this neuropathic pain from my leg, and so what do you do when you have pain? You want to curl up and you don't really want to move, but then your body tenses up and the pain becomes worse. So if you very slowly and very gradually start range of motion where in the body part where the pain is starting, and then gradually you can build up and get a little more aggressive with your movement, but that oftentimes will help people with their pain. Now, just any one treatment is probably not going to be the answer for people with neuropathic pain. Usually, if you're lucky that you take one treatment and it makes your pain better and you're ready to go on and continue with that treatment, it's usually the treatment has to be continued. It's not usually a one-time event. But if it's one treatment that works for you, then again, you're very lucky in that regard. Most often there will be several treatments that will have to be tried and a combination of treatments that will be used. So people have all different kinds of things that they will try with positioning, and maybe they'll try some over-the-counter type of pain medications, lidocaine patches, some of these capsaicin rubs, that will help reduce the nerve activity at the site of the pain. Whatever you decide to do, just make sure you're working with your healthcare professional, that you have reviewed all of these over-the-counter medications, anything in addition that you're trying to use to help reduce your pain. So you wouldn't necessarily want to go maybe to the acupuncturist without checking with your healthcare professional to make sure that your body is in alignment, that you can tolerate that kind of treatment. Nor do you want to start going out and taking some herbs or supplements, because a lot of times those will interact with other medications. There's a lot of foods that we eat that interact with medications. So you just want to be sure that you have really talked about everything with your healthcare professional to make sure you're on board with that, so that you're not hurting yourself because you think, oh well, I bought this over the counter. I bought some Bengay or something, and you're rubbing that into your skin, which is penetrating your skin and actually entering into your body. So you want to make sure that that's not interacting with any other medications that you might be taking, that you might have some complication, or that your medication is then rendered ineffective because you've taken a counteractor to that particular medicine. So with a lot of effort and treatment, you can certainly get treatment for your neuropathic pain. There's even some surgeries if it gets to that point. Hopefully you'll be able to control that pain sooner rather than later, and maybe you won't have to get to that particular point where you have to do something very drastic. People do. It's not the end of the line. It's helpful, and then they're able to move on too. But oftentimes it's a combination of different treatments that will be the source of the solution to your pain. One thing I do want to mention, and then we'll get into some questions, but one thing I do want to mention is that if you start any of these medications, the anti-seizure or the antidepressant medications, those need time to build up in your bloodstream, so you have to take those for a while before, it's usually about 6 weeks before the full amount is seen in your bloodstream. You'll probably have some noticeable difference in your pain before 6 weeks, but it takes a full 6 weeks to build up the amount of medication in your bloodstream. So it's not the kind of thing that you take only when you have the pain. You have to keep taking these medications to maintain that level in your bloodstream. And then the other thing is, if you decide that they're not working, or if you have a side effect, or for some reason you decide you do not want to take those medications anymore, it's very important that you work with your healthcare professional to start tapering off those medications. Suddenly stopping those medications can actually result in an increase in pain, and it also makes it more difficult to treat the pain if you just suddenly stop the medication. It sometimes makes it more difficult the next time you try something. So, just suddenly stopping can really create a difference in your pain. So be careful about those things, but there's lots of things you can do, and you can refer back to the blogs, or you can write in questions if you have anything else. Another thing to mention is pain and autonomic dysreflexia. There's been a lot of research that's come out about that. In fact, when I wrote the blog last week, there was an article that came out about tying the tooth together. And I found it very interesting because in the study of autonomic dysreflexia, I try to read every single thing I can possibly find about this because it's such a phenomenon. And as more and more information is coming out about AD, we're finding more and more links to all different sorts of common complaints. So pain and AD are definitely tied together. There is a pain component to the dysreflexia. So if you think about, if you have dysreflexia with most common symptom, which is that pounding headache, that certainly is a pain component. But pain in your body can trigger an AD response. Maybe you didn't realize that you were having pain, but maybe the result of the pain is an episode of autonomic dysreflexia. Maybe the dysreflexia is triggering the pain, so it goes back and forth both ways. So an important piece of information. Autonomic dysreflexia is the autonomic nervous system has lost control of its function, and so anything that your body does automatically, like breathing, your heart beating, and the orientation, the initiation of pain can trigger an autonomic dysreflexic episode. So it can be very severe, which is what most people know. They experience it usually relatively early on in their life after spinal cord injury. Sometimes it doesn't come on until much later in life. So it's kind of elusive in that way. People are very very knowledgeable and experienced about these really severe episodes of AD. But what we're finding is there's a lot more AD out there, but they're milder episodes. So somebody might get a stuffy nose. Well, they say, well, I can't be AD because I didn't have that real severe headache. When in fact it is, a stuffy nose is one of the other signs that's not as often frequently seen as that severe headache. And since it's not a real overt kind of thing, people don't think they're having AD when they actually are. So this is something that there's a lot more study that needs to be done about dysreflexia. And as people write things in the blog, it's always interesting to me to see, because I think, aha, a little hidden episode of AD. So it's been kind of an interesting progress to just study that in and of itself. So on to the questions here. We have a lady who's writing in about her husband who has discomfort with a ventilator tube in his throat, and it's at its worst when spasm starts. And so she wants to know if there's any information about this. Well, I will tell you right away, it is not uncommon at all for people to have discomfort with that tube. It's it's in a place in the body where people feel at the base of the throat there. So most people have some sensation there. They might have full sensation, it may be abnormal sensation, but they do have some sensation there. And it is a foreign body that's being placed through the skin into the throat to aid with breathing. So this is not uncommon. I think most people who do have the ventilator tube will tell me that they are having discomfort from that tube being there, especially when they turn their head and the area gets pulled. And so this is not an uncommon situation. So the question is, of course, what can be done about it? And she's asking if there's any other information about other ventilators. There are several ventilators that are on the market, but it's probably not the ventilator itself. It's the tube. It's the tube itself. So you should talk to your home health nurse or your healthcare professional, because there are different tubes. So maybe this particular tube is not the one for your husband. Maybe there might be a different brand that is molded differently that might be more comfortable for him. There's all different kinds of tracheostomy tubes that you might be able to switch to another tube that's actually going into his body. And then the other thing too is that you say it's when spasms start. So if you could get those spasms under control, either through medications or sometimes people can use some throat sprays that help reduce those spasms. I don't want to recommend anything, because I really think that anything to do with your breathing, you should talk directly to your healthcare professional to see what can be used with your husband and what shouldn't be used with your husband. I can only provide some questions that you might want to ask about. So that might be something. People have spasms in their throat the same as they have spasms in their legs. So there might be some medication that might help reduce those spasms, or some other kind of coating treatment for the throat. A different tracheostomy tube might be the answer for you, or sometimes people have metal tubes versus plastic tubes. Sometimes they like one better than the other, and there's not really a rhyme or reason for it. So some people really like the plastic tubes. Some people really prefer the metal tubes, although the metal tubes always seem, to the person who's not using it, they always seem to be a little bit, I think, harsh. They look harsher. But some people actually prefer the metal tube. They have less reaction to it than to the plastic. So again, I think that experimentation is going to be your key here. Sometimes adding maybe a little more humidity to the ventilatory process. So the ventilator, some of them have humidity that's added, maybe upping that humidity so that it's not quite so dry in there sometimes helps. So there's some good questions to ask with your doctor about there. So is there information to help identify other brands? Well, you can certainly go on the computer and Google tracheostomy tubes. And if you go to the images part, you'll see all different kinds of pictures of them. But you just Google tracheostomy tubes and all different kinds of ads and brands will come up there. So you think, okay, now here's 100 different kinds of tracheostomy tubes. Oh my gosh, which one do I need? Well, that's when you start turning to your healthcare professional and asking them, what they would recommend. If you do not have a pulmonologist, it might be a good time to ask for a referral to pulmonology. They know the ins and outs of all these tubes, and they will be able to size up your husband and say, well, he has a large neck, or he has a small neck, or, he has this kind of opening in his tracheostomy, and we need this size of balloon, or we don't want to pump up the balloon. So they'll be able to give you all that kind of information, and that's where you need to direct your key. Once you get connected with a pulmonologist, they will probably have a nurse that works with them, and you will be able to continue to work with that nurse and go through the process of finding the right tube for your husband. So here again, it's one of those trial and errors, but it's not quite a mystery. When you get to somebody, the pulmonologist, that's really familiar with those tubes, and again, investigate on your own, Google tracheostomy tubes, and start looking with your husband. You might see something that is on one particular tube that you think, that would seem to be the key. You'll be well educated just by looking at them, and then when you meet again with your doctor, your healthcare professional, you'll be able to get some more ideas about what to do. So there is help and hope for you out there. You just need to make that right connection, and that right connection is going to be somebody who's examining your husband and picking out something specifically for him. So that is going to be a problem that you're going to be able to check off your list, and that is surmountable. So I'll wish you well on that. So that's going to be a manageable problem. We have another person who's written in today that has some neuropathic pain that I'm talking about, full body, all day, every day. This is not uncommon to have these extreme events of pain, and he's 4 years past injury. So, I think we can all appreciate to have just pain constantly, just for years. Oh my gosh, how horrible. So he's taking the gabapentin. That's one of the anti-epileptics, 800 milligrams 3 times a day. Now, I'm assuming that's 800 milligrams each time, 3 times a day, as opposed to 800 milligrams total divided over 3 times a day. He says he feels pain all day, but these meds most days subside it, but he knows it's still there, and then there's some days when it's just over the top. He does take some Valium plus Tylenol, and that can help, but sometimes not too much, and the side effects of the pain meds block his valves. Yeah, that's going to happen. Not so much with the gabapentin, but with some of the other things that you're taking. So he's got his question. He also has a major question about spasms. So let's tease out some of the information in this question, because this, I have to say, John, this is the kind of thing that we see in clinic all the time. There's multiple factors that are playing into this. There's different pain treatments. It's kind of sort of working, but it's not giving you the satisfaction that you want, and each day is really different. So how can we tease this out? Well, one of the things you can have checked into is the question about your spasms, if the spasms is what's causing the neuropathic pain. And so that would be something to treat those spasms. I don't know if you're on medication that keeps your spasms under constant control. You mentioned you're taking some Valium, and sometimes that's used for spasm treatment, but there's some better medications that will help you with your spasms. So you might want to talk to your physician about getting your spasms under control. That should certainly help. And then you're on a 800 milligrams 3 times a day of the gabapentin. That is not an extremely high dose. That's a higher dose, but it's not an extremely high dose. There are some people who are taking more gabapentin than that. So that might be an opportunity also to talk with your doctor. The thing about the gabapentin and the pregabalin, gabapentin being the Neurontin and the pregabalin, the Lyrica drug, is that after a certain amount of time, your body builds up a tolerance to them. So these are medications that over time people are upping a little bit. That helps with their pain as they break through their pain. Then this helps. Now, if you're having these days when some days this just isn't working, and you're having this breakthrough pain, those might be days when you want to add maybe a different medication just for that day when you're having these extreme periods of pain. So 3 things to talk about medication-wise with your doctor is treatment for the spasms, if you need to up your gabapentin, and then what kind of medications you might be able to take on those breakthrough days. Now, that's only using medications, and you might not feel like you want to take more pills, or you might not feel like that's maybe the answer for you. So something that really helps your pain, which, as I mentioned before, it's kind of counterintuitive. When you have pain, you don't want to move. But when you have the pain or just regularly through your day, if you have someone who can help you do range of motion exercises very, very gently, it will help your spasms, it will reduce your spasms, and it should also help your pain. Now, it may not take it away just by doing the range of motion, but it will significantly lower it. And people are kind of shocked when they find out that just moving their body around, our bodies want to move. That's what our body wants to do. And so when you have a spinal cord injury or some other disease or impairment that keeps you from moving, your body's saying, hey, wait a minute, I need to move. I need to have somebody move. That's when your muscles get cramped. If you think about a time before you had your spinal cord injury, and maybe you were just had the flu and you were laying around in bed for a while, your body gets kind of all cramped up because it hasn't moved enough. So, it's the same kind of thing. Even though you don't feel it, your body wants to move. So that's going to be an important thing. If you're finding that you're not getting satisfaction through oral medications, you might want to go to the next step up and look at some other kinds of treatments as far as doing the biofeedback, moving, doing some of the exercise programs that are available. You might want to move into a higher dose of pain control that can be given through intrathecal delivery. That's a little pump that's placed in the abdomen. It looks like a cardiac heart pacemaker, but it's placed actually in your abdomen, in the belly, and there's a tube that's fed around to your back. And the tube is entered into the area where your spinal cord is. The tube does not go in your spinal column, but it goes to that sac that holds the spinal column. And some medicine is delivered into that, so you can take really high doses of medicine, and the medicine then bathes the spinal column and relaxes it. Most often, Baclofen is put into these pumps, but I want to caution you about that because Baclofen is a drug that's usually taken for spasms, but there has been some evidence that it stops neurology healing, some neuro healing. So it stops regeneration of recovery for spinal cord injury. Now there's some evidence of that. There are many people that take Baclofen and they're doing just great. And then there are some people that they've heard about this evidence so they don't want anything to do with it. That's a decision that you have to make. The Baclofen pumps, though, they were designed to hold Baclofen, but other medications can be put in there. So you don't have that medication going through your entire body, but it's just going into that area bathing your spinal cord. Some other things that you might be able to do if you have spasms, you might be able to relieve some of your spasms using Botox injections. That has seemed to be very helpful for a lot of people with neuropathic pain because then the spasms are relaxed so the nerves aren't tensed up so they don't get that neuropathic pain. That has been, the Botox has been, it's seemingly right now, it just seems like every time I turn around there's new treatment being used with Botox very effectively. So we'll have to see in the long haul how that all plays out with people. There are other procedures that can be done. John, I think you're far off from that, some of the surgical procedures. There's a real divide in spinal cord injury. Certainly those are kind of more the last-ditch efforts, where some of these nerves are cut, and of course in spinal cord injury we want to regenerate your nerves, we don't want to cut them. So those are kind of last ditch, but I think you have plenty of options way before you get there. I don't think you're even close to that yet. So I think that gives you some options, and hopefully that will be able to help you with control of some of this pain that you're having. Okay, so the next question is a discussion about acupuncture for treatments of neuropathy. And this is somebody who has spinal cord injury at L1. So acupuncture, as you know, is a Chinese medicine, and it's very common in Asian countries. Not so much common in the United States, but becoming more popular over here. A sterile needle is injected into certain sites on your body. Sometimes the needle is twisted by the person delivering the acupuncture, and then sometimes there's an electrical charge that's delivered to that. And that seems to break up the pain sensation that's being sent to the brain, which is the neuropathy and that feeling of tingling or numbness that's going on. So there are people that have gone for acupuncture treatments that are just find them just absolutely phenomenal. They've gotten off their pain medication. You have to go routinely. It's not like a one-time treatment and you're done. But I've had people that just, think this is just the greatest thing ever. I've had other patients who've gone sort of with an open mind. I felt like they had an open mind about it. They would ask about it, and they would go try it. They found no relief from it. So it's almost something you have to try to see if it works for you or not. There is a subset to the acupuncture. It's a little different. It's called Acupressure. You might want to try that before you actually go to the puncture. The puncture, they're actually going to puncture your skin and put a needle in there. The acupressure is going to be applied to these same areas. They're zoned out areas. They have charts that will show where you put the pressure or where you put the needle for different treatments. And so these are when you go for acupressure, it's pressure that's being applied externally to the skin that is providing this relief. So again, as I say, there are people that I've seen that have just completely thought this was just the most wonderful thing. And then I've had everything in between to people who said that just did no good. Why did I waste my time and money on it? So I don't really have a feel for who it works for and who it doesn't work for. My only personal sense is that it seems that if people go with the mindset that this could possibly help them and they're open to it, they seem to have better results. Some people think, well, that couldn't possibly work. And so when they go with that attitude, guess what? It doesn't work. So I've not seen anybody who went and was suddenly converted to believing in this kind of thing. It seems like the mindset is the most important thing. However, I will say if you're taking medications and you believe the medication is going to help you, people have a much better result than if they say, well, I know this isn't going to work either. Then they don't have such a good result. So trying to get your mind set a little bit in that way to help you think that you're going to be getting better, to seeking treatment and picking out the treatment that you think is going to help you is going to be the key element for that. Okay, so is the treatment for TM different for pain treatment for SCI? And Beth has written this question in, and actually, technically, no, because the treatment process is pretty much the same. TM is transverse myelitis. It's an infection that people get, and so they have essentially a spinal cord injury, but from an infection as opposed to a trauma. And I like to mention that when we talk about SCI, sometimes people who have spinal cord injury from disease feel like we're only talking to people who have trauma accidents. But when we're talking about SCI, we're talking about both. So you can have an insult from transverse myelitis, and the pain is it's the nerve pain that's causing the trouble. Now, if you still have infection in your body, or if you're in the middle of the process of going through the first experience of developing the transverse myelitis, sometimes people have different levels of pain. Sometimes they have the transverse myelitis and they don't have any pain at all because they suddenly lose sensation below the level of their injury, which is from disease. So basically, the pain process treatment is pretty much the same. Okay, and then we have, we seem to be having a lot of connectivity problems. I know it was hard for us to log on. I don't know if it's the weather or what's going on today. But back to our friend John, who's having the spasms and the neuropathic pain. He's having some jerky movements when he's sleeping, and so this will last for a couple hours straight. And so he's had to go to the hospital to quell the spasms. And he sometimes looks like he's having a seizure, and he's not talked to anyone with spasms like this. So now, of course, John, I don't know you. I've never seen you. And I can only suggest questions that you might want to ask somebody. But there is some evidence that people with spinal cord injury actually have what would be similar to restless pain syndrome, and where they get this jerking. So even though they have no voluntary movement in their legs, they get this extreme jerking in their legs. I'll call it similar to restless leg syndrome. I'm not sure, in fact, that's what it is. It's probably more the spasms. So it sounds like if you're not on medications for treatment of spasms, it sounds like you need to be on those to help quell them. I actually was involved with a patient who had spasms like this that had to go to the hospital. Now, this patient had a different injury type than you had. So what he would do he was use his spasms to help him transfer. So he was only paraplegic, not paraplegic, or quadriplegic, not completely paralyzed, but he had some ability, but without the use of his spasms. So see, he was not eligible for the Botox, or he was not eligible for the Baclofen, because if we took away his spasms, he would not have his independent mobility anymore. So it was quite the conundrum. But the only way that he could control the spasms and this horrible pain in his spasms was to go to the hospital and to have IV medication. Oh my gosh. And of course then he would just be like a noodle. So, it was a real trade-off. But it seems like the thing that's helping people with their spasms and with this restless leg or this movement in the night, it seems to be like just some range of motion before you go to bed. I know, people think, oh no, that's not a pill, it's not a medication, it's not something big. How can that help? But it seems to help. So looking at some medication to control those spasms, and then, stretching your legs out to kind of, if you can fatigue your muscles, they won't spasm. So that doesn't mean, jerking them around or whipping them around as fast as you can. That just means doing some gentle range of motion, maybe even moving your leg joints through all of it, maybe 20 or 30 times on each leg. It's going to require a lot of assistance and dedication with someone to help you do that, I realize. And it's hard to lift a person's leg and to do all of this. But while they're doing it, take advantage of this time and imagine yourself, look at your leg moving, imagine it moving, and using some of that imagery to help you think about. It seems to help in some of the regeneration. So that's probably going to be the key there. Let's see if there's some other questions here. Back on the ventilator questions. There's a valve that goes on the trach, and it says, do they vary much between different brands? Actually, they look very much the same, but there is some differences in how much pressure is applied to move the air through the valve, and how long it's being placed on there, maybe if the valve is on too long, or if it's too tight, would that increase the spasm? So there is a difference between valves. And then the question is, what guidance is followed when the ventilator is selected? So you need to check with the ventilator to make sure that the valve and the trach, that it all hooks together and works. They're pretty universal, but you want to make sure that they all work. And so, again, checking with your pulmonologist is going to be the key here for getting that those spasms in that neck to decrease and to get that more comfortable. After a certain amount of time, people seem to get adjusted to having the trach there. Some people never find that, it's always something abnormal. It always feels abnormal to them. And then other people seem to, get more comfortable with it more quickly. So that's going to be the kind of thing that you're going to have to maybe trial a few things. Sometimes if you work with a pulmonologist or your home health nurse, sometimes you can work through them with companies who might send the pulmonologist or the home health nurse a couple of different samples of different kinds. They're not going to send them to you because the liability for, try this trach and see how it goes. They again also have not examined your husband. So they're not prescribers, so they can't say, here's some different trachs, try which one and see which one you like, because depending on the size of the trach is going to affect, and the valve and the balloon is all going to affect the settings on the ventilator. So you can't go from one to another without making slight adjustments. So again, you have to work with somebody who really knows those ventilators. But if you talk to them, They can talk to their supplier. They're ordering the supplies all the time for people. So if they are a person, people tend to like what they know. And so if they're constantly ordering one brand of tracheostomy tubes, maybe that's their preferred brand, they might be working with a salesman, or they might be able to call that company and say, we've got this problem. Could you send out a couple of tubes? And they'll send them to your physician, or most likely to your physician, maybe to the home health nurse, that you can try some of these different tubes. And so that might be an option, but there again, you have to have that person that's willing to work with you to do that, because as I say, you can't just change these willy-nilly and say, oh, this one seems to fit better, but in fact, it might be that it might not be the right one for that particular ventilator. So all that has to be coordinated. It's not really something that you can do on your own. You can educate yourself about it, but you need to find somebody that's really going to work through these issues with you, and somebody that you can call, in the middle of the night or in the evening when things are the weekend, when things, if things go south or whatever happens. So that's really where you need to go. But educate yourself about those tubes. Just look on and see what kinds there are, so that you know what questions to ask when you go there. What about this kind? What about that kind? Go armed with your information. Okay, so we have another question about somebody whose foot hurts all the time, especially on the bottom around the big toe. Is this neuropathic pain? She is a C4-6 incomplete, and topical meds and Advil don't work. But I'm glad that you tried them, because at least you're trying to deal with this. So on the bottom of the foot and around the big toe, now if it's only happening on one foot, now, sometimes we get so locked into what we have going on that sometimes we don't look at other things. So that is the bottom of the foot and the big toe. That's that part of your body is being managed by one of the very last nerves that's coming out of your spinal cord. So it's starting from the sciatic nerve, and it's going all the way down your leg and all the way down into that big toe. So could it be neuropathic pain? It absolutely could be. It could be something about that particular nerve just on one side of your body that's got an irritation for some particular reason. But as I say, having a spinal cord injury is a pretty big deal. And so it seems like everything evolves around that spinal cord injury. And so sometimes we don't look past that. But talking about having this pain on the bottom of the foot and around the big toe, if you did not have a spinal cord injury, the first place my mind would go would be, do you have gout? It seems like people more and more are having gout these days. It's kind of ironic. For a long time, it was kind of thought that it was kind of a thing of the past. But people with spinal cord injury also could have kidney problems, which is a major impactor of gout, and then having that one area of the foot in particular, if it's red and if it's swollen, it could be some pain from the gout. If you were having gout without the spinal cord injury, the pain would be so severe that you wouldn't be able to stand it. But since you have the spinal cord injury, you might be feeling the pain, but it might actually be muted from the gout. So I have a patient who is paraplegic, and his health care provider, his caretaker, brought him in one day and said, oh, he stubbed his toe and it's red and it doesn't hurt, but, we thought we should bring him in because, it looks like it's getting worse. Well, when we took off his shoe and sock, my goodness, it was like he had a red sock all the way up his leg. He had no pain whatsoever. But what he had was not a stubbed toe. He had gout, and he didn't feel it at all. Of course, his spasms had increased to a significant event, and I wondered if they were really there because he stubbed his toe or because his spasms had increased so much. But what they had said was that he had stubbed his toe. So just because you have a spinal cord injury, unfortunately, it does not exempt you from all the other things that could possibly happen. So since the pain's also on the bottom of the foot, I would not think of ingrown toenail or something like that, which is also pretty common because sometimes people get shoes. They don't feel that they're rubbing against their toe and they get an ingrown toenail, and then they have all these problems. So the question would be, is the pain on the bottom of the foot hurting because the big toe hurts, or is it the big toe is causing the pain on the bottom of the foot, or if the bottom of the foot's causing the big toe to hurt, or if it's neuropathic pain. So you've tried the topical meds, so it's a good time to see your healthcare professional, have them examine this toe, ask them about gout, ask them about ingrown toenail, ask them about a blood clot. It's kind of unusual but not impossible to have a blood clot down there in your toe. Look at things like your shoes, or if there's anything too tight, socks that are too tight around the ankle. So anyway, so those are just kind of some things to think about. There's one more question, and we are kind of sort of out of time. But Peter's waited, and he says he's late, but okay, he wants to talk about identifying how tethering in spinal cord injury patients. So sometimes the spinal cord gets attached to structures in the spinal column that they shouldn't be attached to. Your spinal cord itself is kind of under pressure in your spinal column. So it doesn't just lay there, but it's kind of taut. So if you think about, you have a ponytail and it's just hanging off your head, and, it kind of flows about. That's not the way your spinal cord is. It's kind of like there's a little bit of tug at the top where it's connected to the brain, and then where each nerve comes out through the vertebrae, and then to the bottom it's under a little bit of tension. So it's pulled a little bit tight, and sometimes it can get stuck up against structures, or something can happen during the spinal cord injury where it gets stuck up against something. And generally what happens is if you don't have a spinal cord injury but you have a tethered cord, they will release that a little bit so that the tension is not, sometimes the tautness on the spinal cord gets to be too much. And so they'll release that spot where it's a little bit stuck. So we will talk about more about that next time, Peter, but that's kind of what the deal is with that tethering of the spinal cord. If it's causing problems, it can certainly cause an increase in spasms, but if it's causing a lot of problems, they will release that where it's tethered or where it's stuck. And so that takes us up to the top of the hour. The time flies by for me. I hope I was able to answer your questions, or at least get you in the right direction. And so with that, Tony, I will turn it back over to you. Thank you, everybody, for coming today.
I just want to thank everyone for joining us today. This presentation was recorded and will be archived by the end of the week. Thank you again, and thanks, Nurse Linda, for taking out some time of your day for answering some questions.
Thank you.
We hope to hear from everybody and see everyone again next month. Thank you.